ॐ सहना भवतु सहनौ भुनक्तु सह वीर्यं कर्वावहै तेजस्विनावदितमस्तु मा विद्विषावहै। ॐ शान्तिः शान्तिः शान्तिः। Dear students, today we are going to discuss about the carpal tunnel syndrome. Carpal tunnel syndrome was first described by Sir James Paget in 1854, but the term was coined by Moorish. Now you all know Sir James Paget is from London, and he was there from 1814 to 1899. And his other contributions to the orthopedics include the Paget's disease, the apophysitis of the tibial tubercle, and the fracture disease. If you look at the anatomy of the carpal tunnel, the bones bound the carpal tunnel on three sides and a ligament on one side, as this picture shows you particularly. The floor is an osseous arch formed by the carpal bones, and the transverse carpal ligament forms the roof. Now, what are the contents of carpal tunnel? So, there are four tendons of flexor distorum superficialis and four tendons of flexor profundus in a common sheath. And there is another tendon of flexor pollicis longus in an independent sheath and the median nerve. And thus, there are 9 tendons and 1 nerve which pass through the carpal tunnel. Now, the synovitis of all those tendons can generate pressure on the nerve. If you look at the causes, various causes for the carpal tunnel syndrome, so we can always divide it into the general causes and the local causes. The general causes include the inflammatory causes, endocrinal causes, and metabolic causes. The example of inflammatory cause includes a rheumatoid arthritis of the wrist joint, or the metabolic causes includes the gout, and the endocrinal causes includes hypothyroidism, diabetes mellitus, menopause, pregnancy, etc. These are some of the important endocrinal causes. Now the local causes, these cause crowding in the space, and hence malunited Colles fracture, ganglion in the carpal region, osteoarthritis of the carpal bones, and the wrist contusion and hematoma. These are some of the important local causes. So to remember the different causes for the carpal tunnel syndrome, we can use the mnemonic pragmatic, where the P stands for pregnancy, R for rheumatoid arthritis, A for arthritis degenerative, G for growth hormone abnormalities, M for metabolic diseases like gout, diabetes, myxedema, etc., A for alcoholism, T for tumors, I for idiopathic, and C for connective tissue disorders, for example, amyloidosis. As far as the clinical features are concerned, clinically 4 different stages of the carpal tunnel syndrome are described. What are those stages? Stage 1. In this particular stage, the pain is usually the presenting complaint, and patient complains of characteristic discomfort in the hand. But there is no precise localization to the median nerve. There may be history of morning stiffness in the hand. When the symptoms progresses, then there is a stage 2. Now in this particular stage, the symptoms of tingling and numbness, pain and paresthesia, now they are localized to the area supplied by the median nerve, namely the radial 3.5 fingers. In stage 3, when the symptoms progress, then there the patient complains of clumsiness in the hand, because now the motor functions are being affected, impairment of the digital functions, and in stage 4, even the sensory loss is seen in the median nerve distribution area, and can be elicited, and there is obvious wasting of the inner immunus. Thus, the carpal tunnel syndrome can be described in 4 different stages. Coming to the various clinical tests. Now, these are provocative tests and they act as an important screening method and as an adjunct to the electrophysiological testing. So the first and foremost important test is the wrist flexion, or what we call as a Fallon test. Now look at this particular picture. The patient is asked to actively place the wrist in complete but unforced flexion. Now if the tingling and numbness are produced in the median nerve distribution of the hand within 60 seconds, we say that the test is positive. Now it is the most sensitive provocative test. It has got a specificity of 80%. The second clinical test is tourniquet test. A pneumatic blood pressure cuff is applied proximal to the elbow and it is inflated higher than the patient's systolic blood pressure. Now the test is positive if there is paresthesia or numbness in the region of median nerve distribution of the hand. It is less reliable and is specific in 65% of the cases only. The third clinical test is the median nerve percussion test. Now look at this particular picture, how the median nerve is being tapped. So the examiner gently taps the median nerve at the wrist. He can also use a tendon hammer for tapping. The test is positive if there is a tingling sensation. It is seen in 45% of the cases only. The fourth clinical test is the median nerve compression test. Look at the finger. In this, the direct pressure is exerted equally over both wrists by the examiner. Now, there are 2 phases. First phase is the test is first phase of the test is the time taken for the symptoms to appear, and it may be 15 seconds to 2 minutes. And the second phase is the time taken for symptoms to disappear after release of the pressure. And finally, you can also use this particular instrument for 2-point discrimination test. Now this test is positive in about 1/3 cases. And lastly, the electrodiagnostic tests are not very infallible, with 10% individuals having normal values. It includes the nerve conduction test. Coming to the treatment of carpal tunnel, it can be discussed under 3 headings. One is non-operative methods, second is the injection treatment, and third, the surgery. Now, non-operative methods include the initial stages. Non-steroidal anti-inflammatory drugs, NSAIDs, are given. We all know that it is mainly because of the synovitis of those tendon sheaths. So, NSAIDs will relieve the inflammation and hence the crowding, and patient may get symptomatic relief. Now, if it is unsuccessful, then we add steroids. Steroids like prednisolone for 8 days, starting with 40 mg for 2 days. That is 10 mg tablet QID for 2 days. Then tapering by 10 mg every 2 days. That is how we try the treatment with prednisolone. We can also use the carpal tunnel splint as shown in this particular picture. See that this carpal tunnel splint helps to keep the wrist in extension, thereby preventing crowding due to flexion. And injection treatment is indicated in patients with intermittent symptoms. Duration of complaint is less than 1 year, and if there is no sensory deficit or no marked inner wasting. Now you can see here the red arrow showing how the injection is being given in the carpal tunnel itself. Now in the injection therapy, a single infusion of the cortisone with the splinting for 3 weeks is tried, and if still there is no relief, then one has to think for the surgical treatment. Now surgery, this consists of division of the flexure retinaculum. Now you see in the first picture there is a blue color transverse fibrous roof is there, and in the second one that carpal ligament has been dissected out so as to decompress the carpal tunnel. Now this is indicated in a failed non-operative treatment, vein atrophy, sensory loss, etc. So it means whenever the patient comes in a late stage, so instead of trying with the conservative treatment directly, you are supposed to go for the decompression of the carpal tunnel by doing the cutting out the transverse ligament. Now, what is the recent advances? The Chow's technique. Chow's technique is nothing but an endoscopic release of the carpal ligament. It is a reliable alternative for the open procedure, and it has got a success rate of 93.3%. I hope with this much information you should be able to write a nice answer in your theory papers. Thank you. Thank you for your patient listening. Please do visit my YouTube channel, subscribe it, like it and share it. Thank you.